Pulmonary embolus and DVT. This is a problem that accounts for millions of deaths in the United States and around the world. And it's kind of a tricky problem because it has a real variable and non-specific presentation. Some people estimate that more than half go undiagnosed. And there's a 25 to 30% mortality without treatment. So it's kind of a complicated situation that a lot of people don't figure out until it's too late. So the different types of pulmonary emboli are thrombus, air, and fat emboli. We're mostly just going to focus on the thrombus. They account for most of the fatal pulmonary emboli. There are chronic and acute PEs. Of course, that's just going to be a function of how much of the lungs are blocked. And acute can be massive or submassive, which also is a function of how much of the lungs are blocked. So the major risk factors that you hear about are immobilization and travel. You know, the classic story is somebody gets off an airplane, they have pain in their calves, pain in their chest. Surgery, pregnancy, obesity, any type of coagulopathy, including factor V Leiden, any protein S, protein C deficiencies, as well as MTHFR and some of the more rare coagulopathies. Contraceptives are a risk factor. They increase your coagulability. Cancer, some types of tumors can have coagulating substances, and trauma. So the presentation of a pulmonary embolus is almost always accompanied by shortness of breath, is often accompanied by chest pain, and is sometimes accompanied by tachycardia. They classically include tachycardia, but it's not always there. Also hemoptysis, these people are sometimes coughing up blood. And most of them have some type of history of immobilization, surgery, leg swelling, or trauma. And so those can help you start making the diagnosis. Now, the rule that I've heard most doctors say is if pulmonary embolus comes to your mind, then get the test done. There's also this Wells score that's kind of supposed to help you measure the amount of suspicion. So if you suspect there's a DVT, for example, with leg swelling, any alternative diagnosis is not likely. You know, if you're thinking about a pneumonia or a cardiac issue, but it's unlikely in the patient. You also give some points to that. Tachycardia, history of immobilization or surgery, history of DVT or PE, hemoptysis, malignancy. All those things can help you add up how concerned you are about it. And so one interpretation of these scores is if you get a score more than 4, then you need to get some diagnostic tests, some imaging tests. Other than that, you get a D-dimer just to make sure, you know, to ease your mind about it. But again, if you have a suspicion, you might as well go get the test done to make sure that it's not going to kill this patient. So the test that you do, a D-dimer is a breakdown product of fibrin. So basically it tells you that you have clots that are being broken down somewhere in the body. It doesn't tell you where. So the D-dimer can be used for both a pulmonary embolus or a suspicion of a DVT. So both apply to PEs in the end. So if you're suspecting a DVT, if you've got leg leg pain, leg swelling, a positive Homan's test, then you send them to get a venous Doppler to check if they have some kind of a DVT. And that's going to be treated similarly to a pulmonary embolus, depending on the severity of a PE. So the gold standard, they say, is catheterization and angiography, but most people are doing a CT, a pulmonary angiogram. It is not totally sensitive. It's only close to 70% sensitivity, so you can only sleep so well after you've ruled out a PE with a CT angiogram. An EKG is a possible test. This is probably going to be something that you're going to use if you're not sure if it's PE or some kind of cardiac issue. But there are some characteristic EKG changes that we'll talk about in just a second. VQ scans were one of the main tests that used to be used for pulmonary emboli. It compares the amount of perfusion versus ventilation. So they only use these really when people are allergic to dye and other things, other reasons why you wouldn't get a better test done. So some of the things that you do see on an EKG are sinus tachycardia. That's one of the biggest ones, and you can see that on the sample EKG here on the right, as well as a right bundle branch block. If the PE is serious enough, then you can get cor pulmonale. You can get severe pulmonary hypertension, which leads to heart failure. And so with that, you're going to see a large S in lead 1, a large Q in lead 3, as well as an inverted T in lead 3. So once we've identified that we do have a pulmonary embolus, the most important thing is to make sure that these people are stable. So some of the major complications of pulmonary emboli, like we just mentioned on the last slide, can be heart failure or any type of cardiogenic shock that could happen from not getting enough oxygen. So you got to give these people fluids in a lot of cases, and you got to make sure that they're getting enough oxygen. And once people are stable, then you think about anticoagulation. Anybody with a PE or a DVT is going to need anticoagulation, which normally will mean Lovenox or some kind of heparinization in the hospital. These people can be treated outpatient in some cases if they are stable without other underlying diseases. But most people are going to be treated in inpatient at this point. And so once you heparinize these patients, then you start them on Coumadin for long-term anticoagulation. Some cases are going to need thrombolysis. So these are going to be the people that are just not getting enough oxygen to the rest of their body. And so the other reason why you might want to do thrombolysis is if you have other emboli that are just waiting to be thrown somewhere else, and you've got a patent foramen ovale that could send, possibly emboli to the brain. So in some patients that have contraindications to thrombolysis, for example, you have an active bleed, this could be happening in trauma or surgery, then you'll consider an embolectomy. Also, if the thrombolysis just isn't working. So you can do a catheter embolectomy, and you can also do an open embolectomy surgery. IVC filters are used generally with people who you can't anticoagulate, and it's just a little wire filter that you put in the inferior vena cava. So thanks to the people who provided the pictures, and please make comments if there are any errors in this video, as well as if there's just any important information that I've left out. I want to try and make these better, and also make sure you don't use this as a guide for clinical practice. This is just for mainly designed for medical students or anybody else who wants to learn about disease, but please use it as just an overview for learning about it. Thanks.